Welcome to the Prescription for Admission podcast, where we talk about hospitals and hospital-based care, who you can expect to meet, and what you may experience during your time in the hospital, both as a patient and also as a healthcare provider working in a hospital. My name is Dr. Monique Nugent. I am a practicing hospitalist and also the author of Prescription for Admission, the book, where I talk about many of the same topics. Thank you for joining me and enjoy the show. Hi, and welcome back to the Prescription for Admission podcast. I am your host, Dr. Monique Nugent, and this is a podcast where we talk about hospitals, all things hospitals, your experience as a patient in the hospital, who's who, what's what you can expect to happen in a hospital stay, and also your experience as a healthcare provider working in a hospital and building careers around healthcare. So today I am your only guest. I wanted to take this time in between seasons, and I'm working really hard doing season 2 and 3 right now, to talk to you kind of one-on-one about what I think are really high-yield topics, things I want patients and their family members, their caretakers to know when they go into a hospital. Now, a lot of this information you can find in the book, Prescription for Admission, which I've written, and funny enough, which the podcast is named after, where I talk about a lot of these things and in a lot more depth in the book. And there's places for you to take notes so that you really make the book something you can learn from and you can use in a hospital stay. So I'm covering things I really want you to know. Things that are really high yield, like I said. The last time it was just me, we talked about hospitals, what different types of hospitals there are, and why I want you to know what's in your community and how you can find out what's in your community so you know what services are offered if you should ever need to be hospitalized or have a loved one hospitalized. Today, I'm going to talk to you about a safety measure or a safety process that we do in the hospital. Something that is extremely, extremely important for maintaining your safety during a hospital stay. And when I talk to people about hospitals and hospitalization, the word that I come back to over and over and over again is safety. Above all, you have got to be safe. You've got to focus on your safety. Your team should be focused on your safety. And safety means a lot of things. Safety from injury. We don't want you to fall down and get injured. Safety from infection. We don't want you to pick up an infection in the hospital. You don't want to have a surgery and get like an infected wound. That clearly would be bad. There's so much that goes into maintaining your safety. But there is a process that we do in the hospital, particularly at points what we call transitions of care, meaning you're changing where your care is occurring. So you were at home and now you need to be in the hospital. That transition point will bring you into the hospital. That's a transition of care. Or you were in the hospital and now you're going home. That's a transition of care. Or those transitions happen in the hospital. You were in the hospital, hanging out with Dr. Nugent on the general medical floors, and you need to go into the ICU. That's a transition of care. So there is a process that happens at these points, these really critical points, that is extremely important for your safety. Yet, I would venture to say, if you do not work in hospitals, notice I didn't say healthcare, I said in hospitals. If you do not work in hospitals, you likely have never heard this phrase. Even if you work in healthcare, there's so many different ways that we all work in healthcare. You may not have had to do this process. And if you do this process, it's something that, though can be cumbersome, you understand the gravity of it and why it is important for safety. So what is this process? This overarching safety thing that Dr. Nugent is talking about, that Monique is on here having us all like gasping for. It is called, drumroll, the medication reconciliation process. Very boring words. Doesn't sound as exciting or sexy as some people would think this really high yield safety thing is. But the medication reconciliation process is vital for your safety. So I am an internist. I don't cut things open. So the thing that I do is prescribe medicines. And the thing that's going to make you the most safe in a hospital under my care, it's not me sterilizing equipment, because I'm not doing that. I'm not going to do surgery that requires me to know like left foot, right foot. All of those type of safety measures, that's something very different, very vital. I'm not belittling that at all. Those occur, and there's really great processes for that. And I think that people know about that type of stuff. There's like the checklist manifesto and that big safety push to say that if we can make OR safe by having checklists, and people have heard about this. Everyone, of course, knows you should be sterilizing things. People are aware that they don't want Nana to fall down in a hospital and get hurt. There's so many different things about safety in a hospital that we think about as a public, people know about. They can say, make sure you tell them about your food allergies because you don't want to eat something you're allergic to in a hospital. Again, vital, important. But the thing that is really important, the thing that is key for keeping you safe, the majority of the public just doesn't know about. Like, how many people are out there walking around talking about doing Nana's medication reconciliation in the hospital? But I guarantee you, when you leave, you're thinking about it. You may not know that exact phraseology, but you're thinking, how do I make sure that we know what medicine she takes? So what is the medication reconciliation process? And why is this so important? I actually took a chance to print off the definitions of the medication reconciliation process from the Joint Commission's website. So we have some really concrete things to work with in our discussion. So the Joint Commission says, the medication reconciliation is the process of comparing a patient's medication orders to all of the medications a patient has been taking. This reconciliation is done to avoid medication errors such as omissions, duplications, dosing errors, and drug interactions. It should be done at every transition of care in which new medications are ordered or existing medications are rewritten. Transitions in care include changes in setting, service, practitioner, or level of care. This process comprises 5 steps. 1, develop a list of current medications. 2, develop a list of medications to be prescribed. 3, compare the medications on the 2 lists. 4, make clinical decisions based on the comparison. And 5, communicate the new list to appropriate caregivers and to the patient. So that is a long spiel I just went on, but all of it is so vital and so key. And I know I am the hospital nerd here talking on a podcast about hospitals and getting excited about reading something from the Joint Commission, but I want to go essentially over all of this with you to make sure that you understand how important this is and how you're going to participate in the medication reconciliation to help assure your safety or the safety of your loved one who's hospitalized. That's really what this discussion today is about. So we'll start with the first sentence. Medication reconciliation is the process of comparing a patient's medication orders to all of the medications the patient has been taking. All of the medications the patient has been taking. And why am I stressing that point? Because what you are taking and what you are prescribed are often 2 different things. So the reason why I say that is not just supplements. People immediately will think, oh, she's talking about supplements. Yes, 100% I am. I'm 100% talking about supplements. But I'm also talking about the reality of the fact that you get a prescription and you pick it up from the pharmacy, you take it for a couple days and it makes you feel really nauseous and not great. So you don't actually take it. And so though it's on the list of prescribed medication, you're not taking it. Or you get a medication, you're taking it, and you're not feeling so great. You go see your primary care or your cardiologist and they say, what? Double the dose of that. And you have enough pills, I'm not going to write you a new prescription until you run out. So just double the dose and go pick up this new prescription when you're done. So what may be written in the prescription that we have access to will say like furosemide, 20 milligrams once a day. You have been taking it, furosemide, 20 milligrams twice a day. So what a patient is prescribed and what a patient is taking, often 2 very different things. And when you come into the hospital and we say, hey, you need to be admitted, let's go over a list of your medications, I want you to tell us what you are taking. Include your supplements. Do not be embarrassed to include your supplements. 100% include your supplements. Just because you include them doesn't mean you're going to take them in the hospital. You can go a couple days without your multivitamin. That's perfectly fine. But if you're taking a high dose vitamin D and it happens that you take it on Tuesdays, you're hospitalized on Monday, We may be able to give you your high dose vitamin D on a Tuesday. Tell us what you're taking, not what you're prescribed, because that's really what this process is about, making sure the things that you're taking is safe. Safety. So it's the second sentence. This reconciliation is done to avoid medication errors such as omissions, duplications, dosing errors, and drug interactions. So those are the type of errors that occur when we're giving people medication in a hospital. Omissions. What does that mean? It means that we don't know that you are taking a medication. Therefore, we don't give you that medication in the hospital. And for whatever reason, something bad might happen. There may be lots of times, like the vitamin D example I just gave, that if you don't get your vitamin D on a Tuesday, the world's not going to end. Nothing really horrible is going to happen. You get home, maybe you can take it on a Thursday, or you even skip that week and take it the next week. You should be fine. But there are times where people are taking medications that we don't know about, and we can give them another medicine that can interact with something like that they're taking, or we're not giving them something that they need. So one of the examples that I wrote about in my book is anti-epileptic medication. I have seen this happen not a ton of times, but more than one time, where somebody comes into the hospital. We don't know too much about them. We do what we think is a decent enough job on the medication reconciliation process, and then they have a seizure later in the hospital stay. We're trying to figure out what's happening, and a loved one says, "Oh yeah, they have seizures. Are they getting their Keppra?" You're like, "Oh, did not know this person was taking this." So an omission, you don't want to miss something you should be getting. And just because you're taking a bunch of things at home, I don't want to give you the false idea that you're going to get all of those in the hospital. There can be lots of reasons, and we're going to get into that really quickly, as to why things may not be safe to take that you usually are taking and may no longer be safe for you to take in the hospital, or it just may not be necessary for you to get that medication. For example, going back to that vitamin D, that's not a thing that you must 100% take every week. You will take it next week. If you're a little late by a day or a week or something, you will be okay. But you don't want to miss something you really should be taking. Now, the second one is duplications, meaning that we prescribe something 2 times. Now, this error I've seen happen mostly on the way out of the hospital, that a patient already has a prescription for a medication, and then we hand them another one, but they may say different things. So going back to the furosemide example, another word for that medication is Lasix. You may leave with now a different dose saying, okay, I have at home one that says take Lasix 1 time a day, 20 milligrams 1 time a day, but I was actually taking it 20 milligrams 2 times a day. Now they've discharged me and it says take 60 milligrams twice a day. People will say, which one should I be taking? And that's fair to say, because you have 3 different prescriptions. So that duplication is extremely confusing. That duplication can become dangerous when classes of medications are repeated. So anticoagulants, for example, or people call them blood thinners. If you're already taking one and then you're prescribed a different one, the last thing you want to do is double up unnecessarily. So duplications, again, big safety problem. The next thing it says is dosing errors. Now, this one I think is kind of self-explanatory. We don't want to give you too much of something that you should not get that much of, or underdose you. So pain medication, it is possible that people take a certain dose of medication at home, they come into the hospital and they get underdosed, and now they're in pain crisis, and everything that comes along with asking for more pain relief, feeling uncomfortable, feeling like you're unheard. People can feel like their caretakers have suspicions of them. And so underdosing is not just pain medication, but any other medication that you get. We don't want to underdose. We don't want to overdose. I think we focus a lot on overdosing, but underdosing and undertreating people is also problematic and unsafe. Remember, we're having a safety conversation. And the next one is drug interactions. I think that kind of speaks for itself as well. If you're taking a medication at home pretty regularly, and we're going to give you a different medicine in the hospital that could interact with that, we need to know so that we're not giving you medications that interact with each other and you have bad outcome from that. So again, why do we do this process? We do this process to avoid errors. The errors of omission, duplication, dosing errors, and drug interactions. The next sentence, it should be done at every transition of care. Every transition of care. The biggest transitions of care that I focus on as a hospitalist are the admissions into the hospital and the discharges out of the hospital. And if you've ever been discharged or ever had a loved one discharged from the hospital, you probably have said, what medications are they going to be taking at home? How do we know what they should be taking? What should they still be taking? What should they not be taking? That transition of care, that transition out of the hospital is a very, very, very acute transition. We want to make sure you're safe. And that is why this medication reconciliation process needs to occur at that point in time. And again, transitions of care, where do they exist? They don't just exist coming in and out of the hospital. They exist within the hospital if you're being transferred into the ICU, if you're going to surgery. And then it also says, interestingly enough, it also says changes in practitioner. So, and that would be, like I go off service. I've been seeing you for a couple of days and my colleague comes on to service. So the Joint Commission is also suggesting that it be done there. And makes a lot of sense. You want to know what your patient's taking. You want to make sure that, again, you agree that all those things are safe for the medical plan that they have in the hospital. So let's go over the 5 steps. Step 1, develop a list of current medications. This is where you as the patient or the caretaker or the loved one are vital. You need to own your information about your medications. Now, what does that mean? I don't need you to know every single name and spelling and every dose of every medication. Medications have complicated names. Like I said earlier, dosings can change. Oh, they were taking 20, but now they're taking 40. They were taking it at nighttime, now they're taking it twice a day. If you have all of that, A+, excited. I'm excited to sit down and do a medication reconciliation with you. If you can tell me where to get that information, A+. I am excited. That is what I mean by owning the information. You don't have to have it all, but you have to tell me where to get that information and make sure that the source of that information is consistent and correct. So some people do it old-fashioned. I have a ton of older patients who keep a little note card folded up in their wallet, and every time the cardiologist changes their dose, they cross it off and they write Lasix 20 twice a day on it. And this here is the most updated thing. Conversely, I have a lot of adult children who come in with a binder and say, this is the last medication list. This is the most up to date. People coming from nursing homes or other facilities should also be sent with that information from their facilities so that we have access to what they were getting and we can do this process, the medication reconciliation process, with the information from the facility that's sending the patient to the hospital. Having that information and owning where to get that information consistently and correctly is really what I want to drive home today in our conversation. I really want you to be the owner of that information. So if the answer is the note card in your wallet, A+, love it. If the answer is, I fill all my prescriptions at CVS, and that is the most up-to-date list, A+, I love it. I went to my PCP last week, and we went through this list, and the PCP has the most up-to-date list. A+, I love it. Have a way of knowing where to get that information. If you own it yourself, again, hats off. But I do understand that the names are confusing. The dosing is confusing. People take a lot of medicines and it's hard for them to remember. So something else you can utilize are apps. If your pharmacy has an app, I know CVS has an app where they keep the medications listed that you're prescribed. If that's how you're taking it, great, exciting. Use that app. A lot of primary care doctors have apps that their office uses, like MyChart. Our hospital uses MyChart. Again, that's a place where you can get that information. And I'm excited when people hand me their cell phone and say oh, here it is. It's on my phone. It's the source of information with confidence. That's the exciting part. Knowing that I'm getting good, consistent, true information. That's important. The second step in the process is to develop a list of medications to be prescribed. And that's what falls on me as your hospitalist. My job is to look and say, okay, we are going to be treating for a urinary tract infection. Which antibiotic will I be using? Or we have heart failure exacerbation and we need to be more aggressive with diuretics. This is a dose of diuretic that I will be using. So I'm going to take that list that I come up with, and I'm going to take the list that you have given me, and I'm going to do step 3, which is compare the medications on the 2 lists. What am I comparing the medications on the 2 lists for? I'm comparing them, one, for duplication, so that I'm not like duplicating dosing in a hospital, say. I want to prescribe Tylenol. They already take Tylenol. Okay, I know that. So I will say continue this medication that they're taking from home. We will continue giving them that type of medication, that dose in the hospital. What's their blood pressure medication that I want them to continue taking? So I'm going to look at everything and I'm going to say, what are things I want you to continue taking so that I'm not duplicating that dose in the hospital? Then I'm going to take a look and I'm going to say, what's everything that I want them to take? And are there any dangerous interactions here? Should I not be giving them something because they have an allergy? Should I not be giving them something because it's going to interact with their Coumadin? Are there any dangerous interactions here? Is there any reason why my new medications would cause them to not be able to safely take their old medications? And then I'm also going to take a look at their old medications and say, is there anything with their current medical condition that precludes them from taking these old medications? So I get this a lot. I will say if I admit 3 patients in the hospital, 1 patient is going to ask the nurse, how come I'm not getting my regular medication? I try to avoid that by having conversations with people beforehand, but it may not always be possible. And the answer sometimes is it's not safe to take that medication, or it may not be safe to take that dose. So if you come in and let's say your kidneys are not working very well, certain medications are just not safe to take if you're having kidney problems, if you're having liver problems, if you're vomiting. We don't want to make symptoms worse. We don't want to make organ function worse. We don't want to injure you. So if it's not safe for you to take your high blood pressure medications because let's say you're in the hospital with an infection that's causing low blood pressure, we're not going to give you that medication at that time. Doesn't mean you won't get it later in a hospital stay, but at this point in time when I'm doing a medication reconciliation, this transition of care from home to into the hospital, this is where I'm taking a look at everything that you're taking and saying, should you continue taking it? Is it safe to continue taking it? Is it going to interact with the things that I'm going to give you that you now need for your medical plan? Those are the really important things. And that process, that's the medication reconciliation process. That's where I'm going to say, okay, I've looked at these, I've compared them to what they were taking, what I want them to be taking, what's safe for them to take, what they can continue taking. And I've made, this says step 4 here, the clinical decision on comparison onto what your new medication list is going to be. And then step number 5, communicate that list to the new and appropriate caregivers. So in the hospital, that's going to be your nursing staff, and the pharmacy is also clearly going to get that list as well. And that's great because our pharmacists, they also do their check. They also go back and say like, oh, what is safe for this patient to be taking now? And they look at things like kidney function and liver function and blood counts. And then they give me a call and say, Dr. Nugent, do you really want to reconsider whether or not they should be taking that much Lasix given their renal function? So that's the whole thing. That's all 5 steps. Develop a current list of things that you're currently taking, not just prescribed, but you are currently taking. Then I'm going to get a list of medicines that I want to prescribe. Then I'm going to compare those lists. I'm going to make a clinical decision onto what medications should be continued from both lists, the ones I want you to take, and then the ones you were taking at home. And then we're going to communicate that to your next and appropriate caregivers. And then this means that we do that same exact process when it's time to go. It means that when you are leaving the hospital, now I have to make a list of medications that you should be taking at home. And I'm going to do that same process again, except now I'm the one responsible. We as a hospital are responsible for knowing what you're currently taking. And so because we're now all on electronic medical records, it's there. I see the list of all their current hospital medications. And then I say, yes, no, yes, no, 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 yes, no, yes, no, to continue taking the ones that you're currently, the new ones that I'm giving you in the hospital. What's the current new medications I'm giving you? And then I compare that also with what you were taking at home and have that same conversation with myself. Do I want them taking this medication again when they go home? Is it safe for them to continue taking this medication when they go home? Is this going to interact with anything new that I am prescribing for them? And this is how I come up with the new list of medicines that you should be taking at home, which is a combination of your old medications, new medications, and stopping medications that are not safe. Now, some nuance happens at this point as well. There may be a point where I say, don't take this diuretic while you're taking this antibiotic. That's the complicated part. That you may be able to restart certain medications later in when you're home. And having a way to communicate that on the discharge medication list or the discharge instructions or the discharge orders is really important. For us, we're asked to make notes. There's also a resume later button. Different EMRs will have different ways of presenting that option to physicians on the time for discharge, but that's a question you can ask as well. Like, hey, I noticed you say dad shouldn't be taking Tylenol. Like, is that forever? Oh no, it's just while X, Y, and Z is happening. Or I don't want him to start taking his blood pressure medication until he sees his primary care doctor and gets his blood pressure checked. Ask really specific questions when you're being discharged about that medication list. Ask all of those questions. Who will be there to answer those questions for you really depends on the institution. A lot of times, I want to say most times, it's going to be the nurse. There are some hospitals that have the availability of having pharmacists to be able to help on discharge, to sit down and go through your medication list. And there are times where I specifically go over the medication list with patients because I am concerned that I want them to know what to do and be very safe and very clear in the instructions, particularly if things are complicated. And then your outpatient pharmacy is also going to get all of the new medications you're prescribed and will have clear directions on them as well. But that's not the only place that I want this medication reconciliation process to occur. Like, this is great. It's exciting that it happens in hospitals. And it is not only exciting, it is extremely, extremely important. We know it is a point of high error probability to happen with medications. Most errors that happen in hospital are medication errors. There are huge efforts going into making sure this medication reconciliation process is done correctly when a person comes into the hospital. And also the same thing when they leave the hospital. We know that it's really, really important. It's vital. It's pushed into us from like day one of residency. Do that medication reconciliation. Get it right. Double check, triple check, and make sure you are confident with what you're sending the patient home with. But I also want you to do the medication reconciliation process when you get home as a patient or a caregiver. Now, why do I say that? Oh, people have a lot of extra medicines at home. They do. People keep medication bottles at home that they should not keep. I have had the opportunity to shadow visiting nurses on more than one occasion. And also when I was a resident and I had my clinic, I used to ask people to bring in their medicines. In the beginning, I would say, please bring in all the medicines you're taking. And then I learned really quickly, I would say, can you please bring in all the medicines that you have at home, like all of the bottles that you have at home? And from those two experiences, particularly going with visiting nurses into the homes, I have learned that people don't throw away medications. People have lots of reasons why. A lot of it could be financial, that I've used this dose of Lasix in the past and I don't want to have to pay for it again. If I need 20 milligrams, I have it, right? But it scares me because that means that there's more risk for error. So, story time. I once had a patient where I was doing that. I said, hey, bring in all of your medicines, all of them for me to see. This was in residency clinic. A very lovely gentleman. And when he put down his bottles, he had multiple bottles of warfarin. Coumadin is another name for it. Is an anticoagulant. has lots of uses. People with atrial fibrillation, which is like a funky heart rhythm, we use it for them. And that's probably where a lot of people know it from. But there's lots of reasons why you may need to take warfarin. And this patient was on warfarin. And he had like 8 bottles. And I was like, well, which one do you take? And he said, well, it just depends on how I'm feeling. And I said, no, what do you mean? He said, well, if I'm having like a thick blood day, then I'll take like 2 of these out of this bottle and like 1 out of this. And if I'm having like a thin blood day, then I'll take only 1 out of this bottle. And I like almost died immediately. My heart rate just like went down. I was like, oh my goodness, that to me was one of the scariest things that a patient could tell me, was that they were taking an anticoagulant with no real prescription and different dosing based on kind of how they were feeling. The patient was safe. His INR was okay. But what I ended up doing was going through his pills, consolidating them, because many of them were the same dose. And so he was just like combining doses and how much dose and this and that. And he was not taking his INR at home. I'm sure someone's listening going, oh, was he checking his INR at home? He was not. So I consolidated his pills because, again, I don't want to throw away someone's medication. That's money. This is the United States. Medicines are definitely not free, right? Consolidated them and gave clear instruction. And then also set him up for a visiting nurse to come and like double check and make sure he was doing okay with his INR and taking his medications the way they're supposed to be taking. And then I had him come back in and just kind of really drill this home that like, this is how we're going to take this medicine, and make sure that he was safe with it. And so I know that people have a ton of medicines at home, half finished prescriptions of antibiotics, medicines that they were taking that made them feel bad, and they never actually discarded them. And so I want you to think about doing the medication reconciliation process at home. Take that list that you've asked all these questions about, that you can say, this is what I should be taking now that I've been discharged from the hospital. Take that list and look at all of your pill bottles and separate out the ones that you need. I want you to take the ones that you need and put those in the place that you take your medicines. Put those in the place you take your medicines so that they're separated from the ones that you don't need. So that's the first pile you're going to make. The second pile you're going to make are the medications that perhaps I say you should take later. So while you're taking an antibiotic, you can't take another medicine. So you know you're going to be finished with this antibiotic in 3 days, so you'll get back on this other medicine 3 days later. You're going to keep that as well. And you're going to put that in the I'm going to take this later pile. But it's again going to be in a place where you take your medicines. And then the third pile is going to be all the medicines that you do not need to take. And I want you to consider going through those. Number 1, discarding things that are expired. Number 2, discarding things you do not need. I have learned not to just tell people to throw medicines away because, again, medicine is expensive. But I want you to consider, for your safety, not having medications in the home that you do not need, because that is unsafe. I don't want you to take something by accident that you didn't know was still there in the pile of medicines. And, maybe it interacts with something, maybe it makes you feel unwell, whatever it is. But I do want you to definitely discard things that are expired. Definitely discard things that are expired. And then sit down and consider discarding things you do not need. Things that I would like you to have in your home are the things that you need to take and are safe for you to take. And that's you doing the medication reconciliation process at home. So that's it. That's the big safety thing that is really important to make sure that you're safe in the hospital and you're safe when you're at home. If you're not going home from the hospital, if you're going to a post-acute care facility, they're going to do that process when you get to the post-acute care facility as well. And you should ask, like, hey, I remember the hospitalist said that I would only be on this antibiotic for 3 more days. Make sure it's written down for 3 days. I don't need to get it for 5 days. Be a part of your care. Be the driver of your care. And now that you know all about the medication reconciliation process, you will be as excited to talk about it as I am, clearly. excited to talk about medication reconciliation. So that's it. That's what I have for you today on our Prescription for Admission podcast. I know that it's not the most exciting thing for a lot of people to hear, but for me, it's like one of the most exciting things that I can tell you and talk to you about, because it's one of the things that is going to make sure you're safe in the hospital. And safety is the most important thing during a hospital stay. I want you to be safe above all. So go home, take a look at your parents' medications and maybe some of those extra pill bottles that they have and see if you can do your own medication reconciliation and kind of streamline the things they have at home. Like, be safe at home. Don't keep extra bottles you don't need. Thanks for listening today on the Prescription for Admission podcast. This is me, Dr. Monique Nugent. I am your host today and only guest. I'm also the author of the book, Prescription for Admission, that I named the podcast after because clearly I lack imagination. And please come back and listen to me talk more about hospitals. As usual, do all the things you do for podcasts, like and subscribe. You can find us on Spotify, Apple Podcasts, everywhere else that you find podcasts, and also on YouTube. So thank you so much.